want to thank the organizers for inviting me to come and give this presentation. Istanbul is a wonderful city, and I've enjoyed myself here tremendously. Can everyone hear okay? So I'm going to go ahead and start. So these are my disclosures. I am an investigator on investigator-initiated research projects funded by Merck, and in the past year I've provided consultation to Sanofi Pasteur on vaccine acceptability issues. So in the talk today, I really want to cover a wide variety of issues. I'm going to talk just briefly about the burden of cervical cancer throughout the world, since that's a primary target of HPV vaccines. I'm going to talk a little bit about global perspectives on licensure, acceptability, cost, and implementation. And then I'm going to transition and talk a little bit about our experience in the United States with HPV vaccination, sort of the history of licensure and implementation and uptake, and some of our failures. And then also talk about vaccination of males, which has been a somewhat controversial issue. So this map shows the distribution of cervical cancer incidence throughout the world. And you can see in the darker green areas are where cervical cancer incidence is highest. So cervical cancer is the second leading cause of all cancer deaths among women throughout the world. And you can see the highest incidence regions are in sub-Saharan Africa and in parts of Central and South America. And this is the most up-to-date information I've gotten, and so the number of countries that have licensed HPV vaccines may have increased, but as of April 2010, there were 110 countries that had licensed the bivalent HPV vaccine. And as of May 2010, there were 120 countries that had licensed the quadrivalent HPV vaccine and had approved these vaccines for use. So the good news is that many of the countries with the highest rates of cervical cancer have licensed HPV vaccines, and that several countries with relatively lower rates of cervical cancer have implemented large-scale HPV immunization programs. The bad news, however, is that few of the countries with the highest rates of cervical cancer have actually been able to implement large-scale HPV vaccination programs. So while the vaccines are approved for use, in fact, they're not getting used on a widespread basis, and there are actually many reasons for that. More of the bad news is that HPV vaccine has been licensed and available in the United States since 2006. So it's been actually over 5 years, but the US has really failed to achieve good or adequate levels of vaccine coverage. So what explains the approval implementation gap, as I might call it? So the vaccines are approved but not implemented. So clearly a major reason is the cost of the vaccine. These vaccines are extraordinarily expensive, and it makes it difficult for countries to purchase the vaccines and distribute them. So the combination of the vaccine cost and countries' resources certainly make it difficult. Countries also have to weigh, countries especially with relatively limited resources, have to weigh health priorities and policies and determine where HPV prevention falls in terms of health priorities. Some of the poorer countries and middle-income countries may not have an ideal infrastructure for vaccine delivery. And there's some countries where there may be cultural issues that might interfere with the vaccine acceptance, and where there may be a history of distrust and a sense of potential exploitation by pharmaceutical companies or by Western manufacturing interests. So the question then is, what can be done and what have we learned so far? So I'm going to start by talking about HPV vaccine acceptability because as sort of an initial step, it's important to understand what are people's attitudes about HPV vaccine throughout the world, and is this something that even initially looks like it would be acceptable? So initially, most of the research was out of North America, the United Kingdom, and Australia. That's where the large proportion of HPV vaccine attitude and acceptability research was derived. But recently, there's really a very hopeful expansion of research that's focused on other countries. By my count, just since 2010, not counting any articles published before then, there have been over 40 articles published in 2010 and to date in 2011 that come from countries outside of the ones I've mentioned. So these represented in these 40 articles are countries in Europe, outside of the UK, Asia, countries in Africa, and in Central and South America. And this research includes research with healthcare providers, parents, and with individuals in terms of their attitudes about getting vaccinated for themselves. I can't obviously go into all these articles in great detail, but suffice it to say that there's a fair amount of variability, but generally relatively high levels of acceptability. So what these studies sort of show is that people are interested in HPV vaccine, healthcare providers are interested in providing the vaccine. Some of the findings, not surprisingly, these are findings that are consistent with findings from the United States and the UK, is a healthcare provider recommendation is extremely important in terms of acceptability of vaccine to individuals and to parents. And they also found that knowledge of HPV and HPV vaccine is an important factor, that many people still don't know what HPV is and the kinds of problems it can cause. And it's very important to educate people about that. What I'd like to do is actually, since we're in Istanbul, is to focus on, in a little bit more detail, on 4 studies that have come out of Turkey and look at what they say. Because what you'll see is that in some sense they reflect some of the research that's been produced throughout the world in terms of variability in acceptability. So in this first study, which is the earliest study published from Turkey, there were 143 adult women who were surveyed in 3 cities, And in this study, they found that over 90% of these women would accept HPV vaccine for themselves. 96% said they would have their daughters vaccinated, and 92% said that they would have their sons vaccinated. However, there was some sense, however, that high vaccine cost was likely to be a significant barrier to the translation of high acceptability to high acceptance. In this study, published in 2010, 717 male and female first-year Edge University students were surveyed. So at this point, there was HPV vaccine was available, and 3 students, 0.4%, actually had been vaccinated. Very low rate, obviously. When presented with a statement, I have an intention to have the vaccine, only 11% of these students said yes. 11% said no, and you can see the vast majority, nearly 80%, said, I have no idea. More women were interested than men, not surprisingly. And the authors really attribute this nearly 80% with no opinion, really, to poor levels of knowledge about HPV and HPV vaccine. This was a study of 525 adult women attending a gynecological clinic in Istanbul. 77% had heard of HPV vaccine, which is encouraging. 1.5%, however, had been vaccinated. But 56% expressed willingness to be vaccinated. And of those with daughters, 89% said they were willing to vaccinate their daughters. And importantly, only 5% expressed concern about HPV vaccine leading to sexual disinhibition. And finally, this was a study of 282 family physicians in Kayseri, Turkey. They were surveyed really generally, not just specifically about HPV vaccine. It was a relatively minor part of the study, but about their adult vaccination practices. The physicians themselves, 3 of them had been vaccinated against HPV. But HPV vaccine was the least recommended of adult vaccines. 36% of the respondents said they recommended it, whereas hepatitis B vaccine, in contrast, was the most recommended by nearly 100%, really, 95%. The authors attributed the low recommendation rate for HPV vaccine, to the newness of the availability of the vaccine, and perhaps the lack of knowledge among the family physicians. So moving on from here, let's talk a little bit about vaccine cost, because again, without reductions in cost, there really is no way to implement HPV vaccination in many countries. The vaccines are extremely expensive, and many people have pointed that out repeatedly, that these are extraordinarily expensive vaccines. And this really creates barriers everywhere, not just in low and middle income countries, but in some ways has created barriers in the United States. Even though much of the vaccination is covered, and people's perception is that these are expensive vaccines and they're concerned about it. But it's a particular barrier for middle and low-income countries, clearly. And it makes it therefore difficult to vaccinate individuals in countries that have the highest rates of cervical and other HPV-related cancers. But the good news is that there's been recent news of attempts to address this issue, and it's very encouraging. The GAVI Alliance, which is a public-private partnership, in part to make vaccines affordable to developing countries, had a press release just earlier this month, well, no, not earlier this month, since it's December 1st, in the middle of last month, in which they said, responding to demand from developing countries, the GAVI Alliance will take the first steps towards the introduction of human papillomavirus and rubella vaccines in developing countries, the GAVI board announced. If negotiations to secure a sustainable price for manufacturers are successful and countries can demonstrate their ability to deliver the vaccines, up to 2 million women and girls in 9 countries could be protected from cervical cancer by 2015. So this is very encouraging news. It's not the answer to all the problems, but it's certainly a step in the right direction. And at least one, if not both, of the pharmaceutical companies that manufacture HPV vaccine have indicated a willingness to reduce, significantly and substantially reduce the price of HPV vaccine for low and middle income countries. So that's the good news. Now what I'd like to talk a little bit about are some implementation efforts around HPV vaccine that have been tried in 4 low and middle income countries. And these were undertaken by a group called PATH through funding from the Bill and Melinda Gates Foundation. So what they really were trying to do is to implement smaller scale, not nationwide, but smaller scale vaccination programs to demonstrate the feasibility of implementing HPV vaccination programs in low and middle income countries. So the countries that these projects were implemented in were Vietnam, Uganda, Peru, and India. And what they found in a recently published paper is extraordinary success with these approaches, so that in Vietnam they were able to achieve 96% 3-dose coverage, in Uganda 89%, in Peru 83%, and in India, because they tried different approaches, the success rate ranged from 68% to 88% of individuals achieving 3-dose coverage with the HPV vaccine. So PATH used a combination of strategies. Some of the most successful efforts were school-based vaccination efforts. They also tried using health centers as a strategy for vaccination. In some cases, they used monthly campaigns, and in other cases, they just did vaccination at a fixed time point. And what's encouraging about this is that it really illustrates what can be done with relatively limited resources. And that a lot of, in advance of PATH implementing these projects, there were a lot of people who said it can't be done. And what's encouraging is PATH was able to actually show that it was possible to have successful HPV vaccination in these countries. However, a cautionary note, because in India, there were concerns that were raised regarding safety. There were some of the adolescent girls who had received vaccine had died after vaccination, completely unrelated to HPV vaccine, but it raised concerns. There were concerns that PATH was implementing experimental clinical trials testing the vaccine which were unfounded. I mean, that's not what PATH was doing. These were not clinical trials, but that was a concern that was raised. And there were also concerns in some cases that adolescent girls were being vaccinated in schools, but that they were not, the program was not getting adequate parental consent for vaccination. And in my reading of the reports of the vaccine program, it's very hard to determine whether that criticism was valid or not. In any case, the perceived lack of responsiveness by PATH and by the government led to increasing anger and the ultimate suspension of PATH's demonstration project in 2010. And you can read letters to the editor in Lancet, as well as in popular newspapers in India, that indicate the amount of anger involved in this situation. Really illustrates the potential pitfalls that may arise with HPV vaccine implementation. And India's had, certainly, there's been a history of exploitation by outside companies, and I think there's tremendous sensitivity to the potential for companies being somewhat self-serving. I don't think it was the case in this situation, but I think there's great sensitivities to that. Shifting now, let's look at the US experience, because I think there's something to be learned by the US, the relative failure in the US to achieve good levels of vaccination. So in 2006, the quadrivalent vaccine was licensed for females with a routine recommendation for vaccination. In 2009, the bivalent vaccine was licensed for females, also with a routine recommendation. In 2009 as well, the quadrivalent vaccine was licensed for males in the United States, but with a weaker recommendation, what was called a permissive recommendation, which meant that it was sort of up to the healthcare provider or the parent to decide if they wanted to vaccinate. But the Advisory Committee on Immunization Practices, ACIP, of the Centers for Disease Control and Prevention, recommended that male vaccination be covered by public funding, by the Vaccine for Children funding mechanism. So it was unusual because it was a weak recommendation, but they recommended paying for it. With increasing evidence of the vaccine's efficacy in preventing HPV diseases in males, the quadrivalent vaccine has now very recently been given a routine recommendation for males. So that just occurred, I believe, in October. So looking at US approaches to HPV vaccination, how well have they worked? Some of the most recent data, which was just published earlier this year, is the 2010 CDC national surveillance data, which shows that just under 50% of 13 to 17-year-old girls were vaccinated nationwide in the United States. Now, what we mean here by vaccinated is they received one or more doses of vaccine. If you look at 3-dose completion, the rates are much lower. They're more like 33% or something like that. Of note here is you can see how well the permissive recommendation for males worked, in that we've achieved less than 2% one-dose vaccination or more among 13 to 17-year-old boys. So a permissive recommendation is pretty unimpressive. Some corroborative data was obtained in a 2010 national survey that my colleagues and I undertook, in which we found about 50% of 14 to 17-year-old girls had received one or more doses of HPV vaccine. Looking at the slightly older age group, 19 to 26, University of Michigan Health Systems survey found that only 18% of 19 to 26-year-old women had received one or more doses of vaccine. And a 2008 North Carolina survey looked at younger girls. Now, remember, in the United States, the targeted age group is 11 to 12, although catch-up vaccination is recommended up to age 26, or was recommended up to age 26. So only 19% of 10 to 12-year-old girls had been vaccinated. So this compares to 80% of girls vaccinated in the United Kingdom, 12 to 13-year-olds receiving all 3 doses, 70% in Australia of 12 to 13-year-olds receiving all 3 doses, and in Canada, most of the provinces are over 80%, but it's variable. In the Netherlands, national coverage was 50% for the first dose of vaccine, but you have to understand, we've only achieved 50% coverage in the United States after 6 years. and I have to move quickly. So in the United States, the problem is vaccines are delivered mostly in medical settings. It's inefficient, expensive, and there's a confusing patchwork of payment systems, including private insurance and vaccine for children's. And in the US, we just don't achieve high rates of vaccination for vaccines that are not required for school entry, which is essentially true for HPV vaccine. What about males? Evidence of the quadrivalent vaccine's efficacy in males has been demonstrated for prevention of warts and anal intraepithelial neoplasia. The vaccine may prevent other HPV-related cancers, including head and neck cancers. HPV-related diseases in males are very costly and burdensome, and as we learn more about HPV, it's clearly more of an issue. There have been questions raised about cost effectiveness. Including males is less cost effective than female-only vaccination, but the cost effectiveness of a gender-neutral approach is better when you have very poor or relatively low levels of female vaccination, which is true in the United States. Also, with more HPV-related diseases identified, such as head and neck cancers, cost effectiveness begins to look better, and certainly as cost of the vaccine itself decreases, as we hope it does worldwide, cost effectiveness will look better as well. There are questions, however, about limited resources. This is particularly a concern for developing countries, so looking at whether to include males or not is going to be a resource issue. It's an issue really because of rising healthcare costs everywhere. But there are pretty cogent arguments for including males. One is the inequity of excluding males, men who have sex with men, who are not going to benefit from the herd immunity through vaccinating females only. Vaccinating males also ensures the greatest protection for women. A gender-neutral approach is more equitable and communicates the important point that has gotten lost, which is that HPV is not a female-only problem. In the United States, relatively poor coverage of females suggests male vaccination would be helpful. Vaccine policy and health policies in general are not always driven by cost-effectiveness research. For instance, a gender-neutral HPV vaccine approach is more cost-effective than meningococcal vaccination. From a public health perspective also, it seems to me that the goal of vaccination is to work towards herd immunity as quickly as possible, and that can be achieved by vaccinating both males and females. So in summary, HPV vaccination is generally acceptable worldwide, but we need to educate both healthcare providers and parents and individuals better. The adoption of vaccination and promotion by healthcare providers is absolutely essential and makes a huge difference. Potential pitfalls must be anticipated and responded to quickly. I believe that a strong immunization policy can minimize the potentially negative effects of negative attitudes, of high cost, and other barriers. A gender-neutral approach to HPV vaccination can also maximize the public health impact. Thank you.